Good afternoon. I'm Marla Dubinsky from Mount Sinai, New York, and I'm joined by David Hudesman from NYU. And while you have lunch, we're going to update you a little bit about the role of new and emerging IBD therapies, but specifically focus on the latest revolution, which is the IL-23 inhibitors. This is a joint providership of MedEd Resources and GI Health Foundation. The educational objectives for today are, first, Dave's going to walk us through a little bit about how we're defining the inflammatory pathways and what the future targets are going to look like. And then again, dive deep into the various IL-23s, just because it's sort of been a lot over the last year and a half, and sort of understanding, do they each differ in any characteristics, or do they have differential treatment responses, and whether or not choosing one or the other makes sense. And we'll also show you quite a bit of data on some of the head-to-heads and the use of IL-23s, particularly in Crohn's disease, in the face of ustekinumab failures or partial responders. So our disclosures, again, Dave and I and Julie Messick, who's the medical writer. These are our disclosures. All right. Here's how you can, this is the accreditation statement that you can get your 1 hour, category 1 credit. Lots of disclaimers, as you can see. All right. And we thank and are grateful to J&J for the educational grant support for this activity. So I'm going to bring Dave up, who's going to walk us through why IL-23 and the emerging cytokines are of relevance and what the future is going to look like for IBD management.
Thanks, Marla. So we're going to have plenty of time at the end for questions. So if you have anything burning during the talk, please come up and interrupt us. If not, again, there'll be plenty of time. So as we all know, our intestine, small and large intestine, account for almost 80% of the body's immune cells, and disturbances of this is what sort of drives inflammation, inflammatory bowel disease. And so when I talk to patients, especially when they first come to the office, about sort of why, one of the most common questions is why they have IBD, why are they getting it? And they usually say there's a genetic predisposition. Over 250, 300 different genes have been discovered to date. And then there needs to be some type of environmental trigger. And whether that's a change in your gut bacteria, whether that's something with barrier dysfunction, but that leads to an immune response that all of us will have. But because of your genetic predisposition, this immune response is dysregulated, right? So your body keeps attacking and keeps attacking. And that's how I like to discuss that with patients. There's a variety of different inflammatory cytokines that are involved with inflammatory bowel disease. And, this sort of first was discovered a little over 20 years ago with the original genome-wide association studies that showed that the IL-23 receptor is upregulated in both Crohn's and ulcerative colitis. And over those next many years, this is what led to the first development of ustekinumab and now our 3 selective IL-23 inhibitors that we have FDA approved. And this is just some of the earlier data looking at cytokine expression in the intestines in patients with inflammatory bowel disease. And what you see here with IL-23, really when patients have active inflammation, right, in their intestines, whether it's Crohn's or ulcerative colitis, IL-23 is upregulated. But when there's not active inflammation, IL-23 really is not doing much. And because of this, I think, speaks to the safety of our agents, right? So really only doing the heavy lifting for decreasing the inflammation when it's active, right? When somebody's in remission that is healed, IL-23 really isn't a big factor. All right, so looking at our advanced therapies, so we have a lot of them now, right? And this is really, over the past 5 years or so, significant increase of therapies for both Crohn's and ulcerative colitis that have been FDA approved. We have over 14 different therapies now. And I think in the next 2 years or so, we're going to have a couple more new mechanisms of action, we hope. Okay, so let's go into a little more detail about our IL-23 inhibitors. So first, ustekinumab, and this was first FDA approved for psoriasis back in 2009, I think it was, and then for Crohn's back in 2019. And really, this blocks the P40 subunit. And the P40 subunit is involved with both cytokine IL-12 and IL-23, right? And this was a very effective agent for patients with both moderate to severe Crohn's and ulcerative colitis. What we've learned is that we probably don't need to block IL-12, right? IL-23 is the main driver of inflammation, and our selective IL-23 inhibitors, guselkumab, mirikizumab, and risankizumab, selectively bind the P19 subunit, which is only on IL-23. There are differences among the IL-23 inhibitors, just like there are differences amongst our anti-TNFs, our JAK inhibitors, our S1P receptor modulators. This is just one difference. If you look at guselkumab, it also binds CD64. Essentially, our inflammatory cells are monocytes and macrophages. These cells have something called CD64, and these cells secrete IL-23. So the hypothesis is that guselkumab not only binds free IL-23 that's floating around, but if the cell releases it, it could sort of capture that and before it's released into the system. Now, again, we don't have clinical data on that, but I think the important point here is there's all of these are subtly different. And as we get more real world data, hopefully head-to-head trials coming in the future, we'll have a better understanding of, maybe one works better in certain situations than the other. Ton of trials for selective IL-23 inhibitors in IBD, and we're not going to go through all of them. I do want to make a comment, though, is as we have newer therapies coming in newer trials, the designs of these trials are not all the same. Some of these trials in Crohn's were randomized withdrawal, meaning patients that got drug that did well initially during induction, they were re-randomized to drug or placebo. So when you're looking at 1-year time endpoints there, that's going to be different than where some of these trials were treat through, meaning you just start somebody on drug, you see how they're doing at the end of the year. So it's really hard to make head-to-head comparisons amongst different trials. But we're going to try to do that here. So this is just looking across the board. And again, these slides, again, we're not going to go through all the different studies. And it's not to say one is better than the other, right? But just to look at the efficacy across the board. So now this is looking at ustekinumab as well as our selective IL-23 inhibitors at induction. And for ustekinumab, it was week 8 endpoints. The rest were at week 12. And really what we're looking at and when we're looking at trials now is sort of the difference between drug and placebo. And you can see across the board, ustekinumab, which is a great drug for ulcerative colitis, as well as our selective IL-23 inhibitors outperformed placebo. In maintenance, you could see as well outperformed for all of the ulcerative colitis trials. These are all randomized withdrawal trials, meaning patients that did well in induction were re-randomized to drug or placebo. So these therapies, and I think all of our therapies, and we're going to hear in a little bit from Asher talking about how we position therapies, but I think if we start our advanced therapies early, right, it probably doesn't matter what therapy we choose, patients are likely to do well, right? Probably one of the most important things you'll hear this whole afternoon is get patients on treatment early. So IL-23 inhibitors work very well early. However, what we've learned is that patients that are TNF non-responders, so usually when an anti-TNF works, it causes T cell apoptosis, right, destroys our inflammatory cells. But patients that are anti-TNF, they lose response to anti-TNF or TNF non-responders, there's this upregulation of the IL-23 receptor. So mechanistically, it makes sense that in patients that have failed an anti-TNF, that the IL-23 an anti-IL-23 will work. And you could see here now looking at same induction trials for ustekinumab and our selective IL-23 inhibitors, looking at bio-naive patients as well as bio-exposed on the right, that these therapies work well in both situations. Now you're going to see in induction, the number is going to be a little bit lower, right? So maintenance we'll see soon, but you'll see lower absolute remission rates, right, and response rates in the bio-exposed and the bio-failure patients, but you still see a nice difference compared to placebo. This is looking at endoscopic remission rates during induction. Again, the numbers are going to be a little bit smaller, right? We're not rescoping a patient at week 8 and at week 12. We're really looking at it a little bit further. All right, moving to Crohn's disease. So these are clinical remission rates across the board with ustekinumab and our selective IL-23 inhibitor. This is just during induction, so it doesn't really matter the trial design. And you really could see nice differences between drug and placebo. And with our selective IL-23 inhibitors, this is some of the highest numbers we've seen in a while compared to vedolizumab and other therapies. So these really work well in Crohn's disease. Looking at, again, bio-naive versus bio-failure. And you could see here, just to highlight, right, the deltas, the difference between drug and placebo, even though the absolute numbers are a little bit lower, across the board with selective IL-23 inhibitors are comparable within bio-naive and bio-failure. And I just want to emphasize again, this is the first time we've seen this, right? Usually with vedolizumab, some of our other agents, if you're bio-exposed, yes, it works in that situation, but that difference, that efficacy is lower. Here we see the same differences between drug and placebo, between bio-naive and bio-failure. Okay, so what about ustekinumab versus IL-23 inhibitors? And this is probably some of the more common questions we get now, right? Should we be using ustekinumab? Should we go right to selective IL-23 inhibitors? Insurance does play a role with the biosimilar and what they're improving. On the left is the VIVID-1 trial. So this is with mirikizumab. And in this design, and they had some bio-naive and bio-exposed, there was no difference that they found with ustekinumab and mirikizumab. On the right are the guselkumab trials, the Galaxy 2 and 3. When you look at the clinical endpoints, the clinical remission endpoints using CDAI on the right, there is no difference between guselkumab and ustekinumab. However, if you look at the endoscopic endpoints, which I don't think we have here, but if you look at endoscopic response and endoscopic remission, guselkumab outperformed ustekinumab. So I think that's something to highlight, and we're going to hear a little more from Marla about risankizumab in our bio-exposed patients, comparing ustekinumab to our selective IL-23 inhibitors. Okay, the next couple of slides, you'll have in your handouts, you can take a picture. I think just looking at the frequency, the induction, the maintenance, for our selective IL-23 inhibitors, you're getting dosing at 0, 4, and 8 weeks. Mirikizumab and risankizumab only IV options. With guselkumab, you have both an IV and a subcutaneous option. When you look at the dosing, right, there's going to be different dosing for induction and maintenance. There's different dosing for some of these agents for mirikizumab and risankizumab if it's UC versus Crohn's. So there's some subtle differences across the board, but most of the time when I'm talking to my patients about this therapy, it's 3 inductions, either 3 IVs every 4 weeks or 3 sub-Qs if you're talking about guselkumab. And then you're giving injections every 4 to 8 weeks. Okay. Talking about the safety profile, this is sort of what's listed in the black box, but bottom line, these therapies are extremely safe, right? So I look at them just like vedolizumab. These are very targeted for the intestine. As I was talking about earlier, really these are only doing something when there's active inflammation. So there's low rates of infection, right? You really don't have to worry about malignancy. I do talk about non-melanoma skin cancers with all my patients, but I don't worry to talk about malignancy lymphoma with our selective IL-23 inhibitors. And really, when I talk to them about it, I say the biggest risk is whether these therapies are going to work or not. Practically, sometimes I will see during induction, sometimes I do see some reactions, whether it's some fatigue or joint pains. Usually it's pretty mild, and when patients get to maintenance, it doesn't persist. This is just a slide on a safety pyramid that was published. I don't use this pyramid, and so I would say, number one, the IL-23 inhibitors are very safe. Number two, though, I think when you're talking to patients, I would not present it like this, right? When I start, I say all the therapies are safe, because the last thing you want to do is say, oh, our selective IL-23 inhibitor, vedolizumab, is a super safe therapy, and we're just, we have to worry about lymphoma with TNF or shingles or, heart attacks with JAKs. And then the next thing you know, they fail a selective IL-23 inhibitor and you're putting them on that, right? So I talk to my patients that all of these are safe therapies. If they're moderate severe on the more moderate end, no extraintestinal manifestations, why not start with something more targeted with a great safety profile? And that's your vedo, ustekinumab, selective IL-23 inhibitor. Okay. So I think sort of this sums up what I just said there. And I'm going to bring it back to Marla, who's going to sort of let us know how we actually use these in our practice.
Thanks, Dave. So again, we've got a lot of data, and Dave just showed you. Now the question is, how do I actually implement this in clinical practice, and how do I choose my therapeutic arsenal? And you'll hear about positioning But the new guidance really are sort of starting to drive positioning. So I'll walk you through the guidelines. First, we're going to talk about first line. And in 2024, the AGA started to put out guidelines based on actually using these published network meta-analysis, which is sort of what we're told never to do, which is to compare across trials and try to make sense of the populations and saying they're all the same, like a head-to-head, and giving recommendations. However, the reason why the AGA was so bold in sort of saying, we're going to take this approach, there's too many therapies, hard to know which one to choose in a naive, and we want to give some guidance to gastroenterologists. And so they really started to think about what does it look like in a naive patient. And probably the first most important point to walk out of here with is that if you have a patient who's got moderate to severely active UC, mesalamines are not effective. I think the first point is that we often, our first line approach to naive patients or people walking in the door is mesalamine, regardless of disease severity. If you have an endoscopic score, a Mayo endoscopic score of 3, which is the highest endoscopic score you can get, mesalamine is contraindicated. It's inappropriate to be using mesalamine, which is approved for mild to moderate only, in a patient with an endoscopic score of 3. It's just not appropriate. So the first sort of comment is, one, I take out of the guidelines because I'm being intent on my language around understanding moderate to severe versus mild to moderately active UC. The other comment would be if you need corticosteroids, you need an advanced therapy. That's the second most important sort of teaching point. Because if you cannot just use mesalamine, be it rectal or oral, that automatically means your patient requires an exit strategy, and mesalamine is not a steroid exit strategy. So two sort of core constructs, if you walk out sort of thinking about how I'm going to define what is that sort of threshold for me to go straight to an advanced therapy. In Crohn's, it's even more intentional, which I'll get through in just a sec. So really, the point is, and Dave sort of showed you the safety pyramid, I would venture to tell you that that also is the efficacy pyramid, meaning in a first-line approach, the way that I think about it is there an urgency? Meaning, does this person earn infliximab? What does that mean? That means like I need speed. This person has pancolitis. They've got Mayo endoscopic score of 3. Their albumin is low. Their ESR is 88. Their CRP is starting to be elevated. In the guidelines, there's sort of this description of a patient who you need to urgently sort of use your drug that you think works the best and fastest. So if you take those patients out that earn infliximab, because we're all comfortable with what that means, meaning I need to act urgently, everything is on the table for moderate to severely active UC. By definition, they are all very similar. Dave showed you sort of the versus within the advanced therapy group, showed you that they're not very different. And I would venture to tell you that it basically, the conversation is, all right, you don't earn infliximab. I'm not bringing you into the hospital. I've got a drug that you can give IV straight through. I've got drugs that you can give IV and then transition to sub-Q. And I've got an oral once a day small molecule called etrasimod, which is Velsipity, right? And those are all essentially, they perform the same in your patient. I want you to walk out of here knowing freedom to have a conversation with your patient around, are you good with daily pills? Do you want sub-Q induction followed by sub-Q maintenance? It's open. There is no preferred choice in a naive patient. Once you've decided this patient does not have sort of more on the severe side of moderate to severe. And that's really the premise of the naive patient. I will tell you though, Dave is right, is that until the strongest data we have on endoscopic improvement in patients that are naive to advanced therapies is really the IL-23s. They have shown us rates of clinical remission, endoscopic improvement, a Mayo score of 0 at rates we have not seen to date. So in the naive patient population, S1Ps have shown, again, very good impact on clinical remission rates, as does the IL-23. And we know Vito, and to be fair to vedolizumab, it wasn't held to the same standard in terms of outcome or endpoints as the newer therapies, because back then we didn't think about histology as an endpoint, but we are moving in that direction. So the newer therapies have a much higher bar to get to become approved. But at the same time, it's important to note that I don't think anyone would differentiate among the classes of patients where you're starting an advanced therapy. So that's sort of the messaging. Oh, and my third point, other than 5-ASA and steroid utilization, adalimumab is the least effective drug for ulcerative colitis, and we should stop using it. And I'm being honest about it. We have IL-23s, we have vedolizumab, and we have S1Ps. Adalimumab is the lowest effectiveness for ulcerative colitis. So again, we don't need to go to a sub-Q anti-TNF, particularly adalimumab. We do have sub-Q infliximab, of course. So what they made the recommendation was taking a whole bunch of studies and sort of throwing them in against each other, using sort of matching across the trials as best as they could. That's what network meta-analysis sort of does. And that's where I sort of showed you where the top efficacy is in the naive patients. And then I just want to make a point about the refractory patient, or those that are predominantly anti-TNF exposed. I want to make the point that IL-23s and vedolizumab, and particularly adalimumab, do not work as well second line. So choose your first line wisely. And that is why I say, essentially, if you have a refractory or an advanced therapy exposed patient, to be fair, and I think Dave would back me up, the best therapy we have on the market today is upadacitinib in a TNF failure and potentially a multi-advanced therapy failure population. And so again, these are sort of what happens in the real clinic and sort of advising on where the field is going. Now, there's going to be one new therapy for ulcerative colitis, hopefully approved between now and 2029. One. So you got to get used to the ones we have right now, and that's going to be another oral small molecule. And then in about 28, 29, and 2030, we're going to have the next revolution of therapies, which are the anti-TL1A therapies. And there will be 3, maybe up to 7 eventually, because there's a lot in the pipeline, but there are 3 that are in phase 3 as we speak. So there's going to be another IL-23 revolution, and it's going to be held against this sort of positioning of our current therapies today, and we'll see how that drug mirrors where these drugs live today. If you want, I can put back this one if there's anyone who wants to take pictures. So interestingly, the ACG takes a completely different approach to guidelines. They use a grade methodology and a key concept if you can't grade the literature and it wasn't strong enough. So the ACG guideline really didn't take a positioning stand. They actually said, they looked at the data and basically any randomized control trial, phase 3 that was approved is going to rank as high quality, right? And all of our drugs met a p-value of less than 0.05 and made it to the market. So the ACG, the only positioning statement they said is based on a head-to-head trial and said you should be using vedolizumab over adalimumab in ulcerative colitis because of a study called the Varsity study. So where the ACG takes a stand on positioning is only when there's a head-to-head trial. So again, AGA guidelines look very different, position the drugs differently, and I would say to you are more helpful because it is getting more and more confusing. And although the methodology is a little bit different, it's sort of trying to be head-to-head without doing head-to-head. To me, the data is correct. It's actually aligning with how we feel about positioning drugs first line versus second line. So I do believe that the AGA does give practitioners and clinicians a little bit more visibility into this confusing landscape of therapies. So let's dig into specifically Crohn's disease. Similarly, AGA came out last year and started positioning using that same network meta-analysis landscape to sort of talk to us about how we should position therapies. So the next slide is going to be sort of this low, intermediate, and high efficacy. So in first line, basically, as you can see, and by the way, the upadacitinib comment on don't use it first line is not because it's not the most effective drug we have, it's because the label says don't use it first line. So take that. So it's sort of a bizarre thing that they put it there because honestly, the deltas between placebo and drug in naive patients are really good. So it's not really reflective of the true network meta-analysis. But that being said, you can see for Crohn's disease that any therapy we have approved for Crohn's disease for a naive patient, other than certolizumab, is ranked as something that has efficacy. And the bottom line, my similar comment about UC, where I said, if someone is moderate to severe, please don't use mesalamine, that in Crohn's disease, there is no approved therapy for moderate to severely active Crohn's that is not an advanced therapy. So there is no therapy other than a small molecule or a biologic for Crohn's disease. The only drug that is approved that is not an advanced therapy is budesonide for a short course in someone with limited mild ileocecal Crohn's disease. Now, how many people have those types of patients? Not that often. Most patients meet a moderate. So there is no role for mesalamine at all, let alone mild to moderate, in Crohn's disease, period. And the ACG did come out and was bold enough to say, at least they took a stance, that there's no approved therapy for mild to moderate other than budesonide for a short period of time. Now, on the refractory, my comment that IL-23 works better and vedolizumab works better first line for UC only pretty well. For Crohn's, it's a little bit different. David showed you that there is not really a significant difference between exposed versus naive patients for IL-23 in Crohn's. So it is not only a great first-line option, it is also a very good second-line option, and we wouldn't probably say that for UC. So positioning patients who are on an anti-TNF or vedolizumab for Crohn's disease, IL-23 is an effective first line and second line for Crohn's, dominantly first line for UC. So hopefully you can start to sort of play your chessboard as how I would use all of these therapies in my practice. And also the idea that, again, vedolizumab and certolizumab is not really an effective therapy for after you've failed predominantly an anti-TNF. Because most of our studies, by the way, the clinical trials, until more recent time, it was dominantly TNF failure because that's all we had. We've only had this explosion since 2022, 23, where the JAK started coming in, and we don't have S1Ps for Crohn's disease. So the S1P market really is solely ulcerative colitis. So that's really one of the differentiators between UC and Crohn's is we have this other oral option for UC that we don't have for Crohn's. So the only really approved small molecule for Crohn's is upadacitinib, because tofacitinib is not approved for Crohn's. So you're really only talking about one. So hopefully we've simplified it. Now, when the TL1As come out, whole other story, because they're going to be for both UC and Crohn's. And the data from the phase 2 trials showed that they are very effective in both UC and Crohn's disease. So this will be an exciting future next 5 years, but we got to get comfortable with how we use our drugs today. I was noting before that there really isn't an approved induction therapy for Crohn's disease other than budesonide, essentially for induction, showing you that all of our drugs have been advanced therapies for induction and not or what we call conventional therapies. For those of you who've heard me speak multiple times, I don't think there's a role for thiopurine monotherapy at all, and I'd say I'm not the only one who could say that. I think we've all moved away from monotherapy thiopurine when you have drugs like vedolizumab, IL-23, ustekinumab, whose safety profile crushes thiopurine. So there really isn't a role for thiopurine monotherapy. If you have someone on steroids, put them on an advanced therapy. It's much safer, much more durable, no malignancy warning with the 23s or vedolizumab. If that's what's driving patient, right? If they're sort of worried about lymphoma, you're like, well, guess what? You're on the drug that has the highest rate of lymphoma. Let's move you to something that has no risk of lymphoma. So that's the concept of thiopurine, why we're moving away from that. So combination is the next hot topic for the next 5 years. Is we will find out in the spring whether combining guselkumab with golimumab, so aka Simponi with Tremfya in one single formulation, is superior to guselkumab alone or golimumab alone. That study is called the DUET study, which was performed in both Crohn's and ulcerative colitis. and we expect the data within the next few months. So we will know whether or not combination therapy is better than monotherapy, and is our therapeutic ceiling, which sort of reaches about, at best, 50% of our patients at the end of a year are in remission. So could we do better than that? And what does transformative look like? And that's why we're excited to see the first combination therapy come out. Now, what gave J&J sort of the confidence that combination is better than monotherapy? This was a study that was published in New England Journal by our late and wonderful great friend Brian Fagan, where they did in ulcerative colitis patients take people who were naive to advanced therapy, a little bit of a different lens called the Vega trial, and it did show that combination therapy, not necessarily for clinical outcome, but yes, for endoscopy, which I'll show you, which is, so Dave, you and I both agree endo should be the primary outcome of our studies, but when you ask someone how better they feel, everyone feels better. So it's not the endpoint anymore for going into clinical trials. It is all about endoscopy, really, as being the primary anchor of what brings drugs to approval. But what this study sort of gave J&J confidence is that 2 is probably better than 1. Now, in the Duet study, they're only taking advanced therapy exposed patients, and then you will get monotherapy versus combination therapy. So we will see that data shortly. Now, Dave showed you that within the J&J program and the Lilly program, they actually used ustekinumab as a comparator arm in addition to placebo. And Dave showed you that particularly with guselkumab, it was superior to ustekinumab as well as to placebo in the clinical trial. Risankizumab didn't compare to ustekinumab in their original phase 3 trials. It was only placebo. That was the Fortify trial. So as a commitment post-marketing, they did the study called the Sequence study. And Sequence was taking patients who were TNF failures and then giving them either ustekinumab or risankizumab. So either giving them Stelara or Skyrizi after you failed TNF. What gave the confidence that these drugs work in exposed patients was from the clinical trial itself. I just want to make a plug to this. Can you use an IL-23 after an ustekinumab failure? All of the clinical trials have now shown that in Crohn's disease, if you fail or are a partial responder to ustekinumab, patients do better when switched to an IL-23. So Dave was noting that we don't think you need 12 and 23, and some of the confidence in what you were probably saying, Dave, comes from the clinical data that actually shows people with Crohn's disease who were failing ustekinumab needed more than every 8-week dosing. When they went into the clinical trials, they actually did better with the 23. So in Crohn's disease, 23 is indeed superior to IL-12/23, which is why I think most of us, and I haven't, to be honest, prescribed Ustek in Crohn's since IL-23 was introduced in 2021. So in our view, there's not really a role for IL-12/23 anymore, now that in Crohn's in particular, now that we've seen the data. The payers may have a different opinion, as we know, because they want us to fail a biosimilar ustekinumab before we go anywhere, but we can fight that with the data because the data actually suggests differentially. I was noting the Sequence trial. So the Sequence trial, again, took patients who were exposed to anti-TNF and randomized them head-to-head, ustekinumab versus risankizumab. And basically, risankizumab was almost 2-fold more effective than ustekinumab in a TNF failure. I was happy to be. I was the last author on this paper in New England. I sort of got an early view into how much more effective IL-23 is than IL-12/23, particularly in a TNF-exposed population. This is probably one of the most important sort of clinical relevant studies to give us the confidence that IL-23 can work as a second-line therapy in Crohn's disease almost as well as it does first-line. Remember, that is not the case for ulcerative colitis. So I do want you to think differently around when you look at data to think about positioning, which Asher will probably double down on. So I've sort of walked you through sort of my brain, and when I look at, clinical trials, what we think about the sequence and what we know about the efficacy in advanced versus naive patients, taking the data that Dave showed, sort of the base case clinical trial data, how our guidelines have sort of spun that into how it can help us make some choices. And so I think, the complexity of IBD, which is increasing, just by the way, not getting simpler, that our guidelines are going to be in real time now. So we're not going to have to wait years for publications because it's live. So every time there's a new therapy that will come to market, it'll be positioned as such, and changes to the guidelines will be made in real time. So you don't have to wait 5 years to find out about how the new therapies actually can impact our decision making. So thank you for your attention, and Dave and I would be happy to take questions. Thank you.